Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker. Dr. Evan Ong most recently received the 2023 Cancer Surgery Top Doc designation and has received the Seattle Top Doctor Award for multiple consecutive years. Dr. Ong's clinical practice focuses on the treatment of all gastrointestinal cancers, with particular interest in the treatment options for pancreaticobiliary cancers, as well as regional and metastatic disease. He offers state-of-the-art treatment, including minimally invasive and robotic surgery for hepatic and pancreatic tumors, microwave and bipolar radiofrequency ablation, irreversible nanoknife, as well as HIPEC.
Hello, my name is Evan Ong. I am the Medical Director of Surgical Oncology and Hepatopancreaticobiliary Surgical Services at Providence Swedish Cancer Institute. This is in Seattle, Washington. Today I'm presenting a topic that I'm excited to speak on. It's concerning the utilization of histotripsy. This is a new technique that's been FDA approved in the last year and a half, and we were one of the first programs to be able to provide that to our patients. So I will be speaking on the utilization of histotripsy in the treatment of liver tumors. I have a disclosure. I am a consultant and speaker for Histosonics. I'm also the medical director at Swedish Cancer Institute. So to begin with, when we talk about tumors within the liver, in this current day and age, we'll talk about treating tumors using liver-directed therapy. And this is a wide range of type of treatments from surgical resection, which is a traditional technique, and is by some considered the gold standard as to what we're trying to achieve, all the way to external beam radiation. And the reason why I put this line between these four kind of topics is because on the top two, the surgical resection and thermal ablation, are procedures that I perform and are more invasive, whereas there's going to be a blend as you go farther down on the list. These are techniques that are more non-invasive. Now, the interesting thing about, even though surgical resection is very invasive, it is extremely effective. I would say that while these catheter-based therapies and external beam radiation, not that they're not effective, but they're not considered curative in its intent. So one of the things that we are always seeking are treatment modalities that can achieve the benefits of both of these things. So one of the advantages of histotripsy is that it can be as effective as surgical resection and thermoablation, but have the non-invasive nature and safety profile of catheter-based therapies and external beam radiation. Well, what is histotripsy? So histotripsy is a utilization of sonic beam therapy, but as opposed to high intensity frequency ultrasound, high intensity frequency ultrasound is meant to be a thermal type of energy. What it's doing is it's trying to treat uh, uh, tumors, stones, etc., by creating heat. Histotripsy is trying to avoid that. And what it's doing is using acoustic cavitation to mechanically digest solid objects. So the technique uses a high amplitude and high pressure versus HIFU, which is a low amplitude and low intermediate pressure. And the idea in HIFU is that you're continuously putting energy in to create an increase in temperature. With histotripsy, what you're really trying to do is create cavitation. And by doing that, you are creating these microsecond pulses that are very rapid. And the point is to create a point effect, meaning that it's only in this area that is targeted to create that destruction. Sorry. So to see this, histotripsy is a novel mechanism of action. I put a picture of the device here. And the idea here, again, is it's taking solid tissue and liquefying it. So you're getting a phase change. And the assumption and kind of the expectation is that the liquefaction of the tissue will lead to cell death in an ordered fashion. Well, histotripsy is not something that has been created over the last 2 or 3 years. In fact, it's been in development for 20 years. Scientists at the University of Michigan actually discovered the idea of histotripsy in 2001. And from there, you can see here along this timeline, it was developed in a fairly a rapid maneuver to try to advance it into the clinical realm. The trials were basically done in 2020. I'll talk about those trials in a little bit. And then in 2022, you can see a submission to the FDA. And then October 6th of 2023, the FDA granted approval for this procedure. Please be aware that since that time, there was a creation of a kidney trial that was started. We're fortunately also part of that. That's actually almost closed. And then what has been in development is there is in Europe a pancreas trial that's being currently done in Spain. As I stated before, talking about histotripsy research, these two trials, the Teresa trial and the Hope for Liver trial, were the two key trials in getting histotripsy FDA approval. Essentially, they were smaller trials, but the idea here was it was trying to demonstrate that in a non-invasive way, histotripsy could destroy tumors within the liver. And you could see here the Teresa trial was originally a European trial. The Hope for Liver is a combination European and trial that was done in the United States. The Hope for Liver trial was a key trial that demonstrated technical success in over 90% of the patients receiving destruction in the tumors. And there was there was a lot of limited complications in the group. And because of that, the device received FDA approval. So when we talk about indications, please be aware that the Teresa trial and the Hope for Liver trial did not provide those type of answers. It was really focused on the fact that there was technical success utilizing this technique in destroying tumors within the liver. For the most part, the FDA approval is that histotripsy is indicated in patients that have unresectable disease. So the current standard of care is that if patients have resectable disease or treatments that could be treated with liver-directed therapies, as we've said before, we commonly aim for that as an option. However, there will be a select group of patients that are considered unresectable. they are considered candidates for liver-directed therapy, but not in the traditional sense. So you can see here, I've listed 5 indications for the procedures sorry, 5 indications to perform this procedure, and understand this is a wide scope of patients. And over the time that we've utilized the device, we've actually tried to provide these as indications for treatment. So curative is pretty self-explanatory. The idea is you have limited disease, and the patient may not be a candidate for surgical resection because they are not fit or functional, or will not be able to tolerate the procedure that it's going to be indicated. And so with the limited disease, using histotripsy, we may be able to, in a sense, reduce the disease in a way that the patient doesn't have any evidence of disease. And by that, we like to say that's considered curative. For palliation, these are patients that typically have bulky tumors that are at the surface or involving the capsule. They are causing pain, and we have used histotripsy as a way to debulk the tumor as well as to reduce the pressure on the liver so that patients don't have pain. That has actually been shown in numerous cases around the United States. Debulking is the idea of removal of a substance of the tumor, not eradication of the entire thing, but to reduce the volume, and that translates into what we think is an extended survival. And that's very common in certain diagnoses, such as neuroendocrine tumor. So we have used that to reduce the bulk of the tumor within the liver, with the hope that we are extending survival. Conversion therapy is the idea of performing a histotripsy in an area of the liver that would allow for a different procedure that could be successful in the treatment of that disease. For example, histotripsy is an accepted mode of treatment for a bridge to liver transplantation. This was spearheaded at the Cleveland Clinic by Dr. David Kwan. And essentially, it is an accepted way to treat HCC in patients that are on the list for consideration of liver transplant, as a way to hold their disease at bay. Additionally, we have used it to be able to allow for surgical resection by treating the portion of liver that we are going to leave behind. So again, the idea is to allow permission of a more aggressive type of surgery and in a low safety profile. I'll speak a little bit about the abscopal effect. This is something that was seen both in animal studies. The abscopal effect, the concept here is that it's an immunogenic effect in which you have a patient with several tumors within the liver. You're treating one of the tumors, and you're seeing a response or reduction in the disease in the non-treated tumors. And the idea here is that we think that the treatment is activating the immune system. This was initially described, or at least has been described in radiation therapy, especially during some of the trials at the beginning in animal models. This was also described in animal models that we have in histotripsy. A lot of that data came out of the University of Michigan. But in terms of seeing that clinically, I personally have seen this, but not to the amount that was kind of expected or has been described in the literature at this point. So at the beginning, when we were doing our initial therapies with that indication, we have slowly backed off the idea of just committing to an abscopal effect as a reason for treatment alone. Oh, so sorry. So this is a video that I commonly present to my patients that are coming in. The company that provides the device is Histonics. The device is called the Edison. It is a non-invasive robotic platform. You'll see here that the Edison system is made up of 3 elements. There is an ultrasound, the treatment head on a robotic device, and a coupling a bucket, if you want to say it's a coupling device. So as you know, ultrasounds can't work without a gel. to be able to couple to the patient to be able to visualize that. And it's the same thing here. The treatment head cannot interact with the patient unless there's a coupling device. So this blue basin, which is you'll see is filled with fluid, and we submerge this treatment head into this basin so that we can actually treat the patient in a manner to destroy liver tumors. Our console to be able to utilize the devices to the right. And you can see that at the bottom of that bucket, there is a membrane that is flexible, and its purpose is to be able to conform to the patient's body habitus. So its flexibility allows for all kinds of body habitus, but it's important in allowing us to couple the device to the patient. We don't want to have any air or pockets that could lead to off-site histotripsy or blockage of the target. So in a manner of speaking, when we take these patients to the operating room, for the most part, patients are under general anesthesia. Before we actually apply the device or the coupling bucket, what we do is define the acoustic window. Once we've defined that, then what we'll do is place the coupling bucket over that area. We'll fill the bucket with approximately about 15 liters of degassed water. That will apply about 20 to 30 pounds of pressure. And so what that means is that when we're trying to actually visualize the liver with that coupling bucket, you do get alterations and pressure within the abdomen that makes it sometimes very difficult to visualize the liver. However, once we've done that, the treatment head goes into the bucket, and you can see that we are able to visualize the internal organs via this ultrasound. Many times we've uploaded the CAT scan of the patient. And the idea of doing this is to be able to fuse and corroborate which of the targets are. Here you're seeing an example of how histotripsy occurs. Energy is outputted through the device, and you can see this acoustic cavitation that's occurring. That acoustic cavitation is used to essentially liquefy tumors. And so once we've identified the target that we want to treat, then we define the parameters. And to do this, this is an example ex vivo. The target is a piece of liver, and we define 6 points of reference from the center. That creates a volume of a sphere. And then we use that acoustic cavitation to essentially mechanically digest the solid component into a liquid. This is approximately 1 centimeter tumor. And this has been sped up, and it takes about 8 minutes to do about a 1 centimeter tumor. Understand that there's not really a maximal size of tumor that we can treat, but in one treatment, probably the maximal treatment size is a little over 3.5 to 4 centimeters. That will probably take an hour and a half in terms of treatment. So treatment time is exponential. And that's actually has to do with the fact that we're dealing with a volume of treatment as opposed to area. As you can see here, the specimen has been liquefied. And typically, one of the questions that patients do ask me is what happens to that fluid? What we expect is that the fluid will be there, but will be resorbed over time. What I've seen in the past is that resorption takes time. So typically we'll do scans approximately, within the first week to define the technical success of the treatment. Then we'll do another scan about 3 to 4 weeks later. And then finally, we do a final scan about 3 months later. Now, we don't always expect complete eradication of the area that we treated at 3 months, but we do expect a reduction in the size of the treatment zone. This is what histotripsy looks like in real time. Well, when we started doing histotripsy, one of the things is that the Hope for Liver trial and the TRISA trial didn't really talk about the technique. It talked about the success, but the technique was a specific form, meaning that it was done with the patient lying supine, and it was done underneath the costal margin or underneath the rib edge. That limited the amount of liver that you could treat, understanding that patients had different body habitus and patients had the portion of the liver that was underneath the rib cage was variable. That also prevented and limited the number of type of patients that you could treat, because now you're only treating to the left side. And unfortunately, patients with the right-sided tumors could not be treated. So at the time when we first got the device, one of the considerations was, how do we perform it? And then how do we select? Because like I told you, the Hope for Liver trial and the Teresa trial didn't really talk about who should receive this. So selection considerations had to be balanced with technical considerations. Well, we talked about some of the technical considerations, like meaning which segments were we going to treat, how were we going to be successful in being able to visualize the target. These patients that many of the patients that came to us were patients that were unresectable and had differing forms of things that could cause problems with trying to perform the technique, such as an ostomy or a gastrostomy tube. Again, positioning was done in a supine manner, but you'll see later on we discovered a way to be able to treat the right side of the liver by putting patients in the lateral position. And that allowed us to be able to treat patients on the right side. Again, this is a new workflow, so the anesthesia people had to learn how to ventilate these patients because we wanted to minimize our target movement. Nursing had to, nursing and technicians in the operating room had to learn a completely new device, and this was something that was new for them. When talking about selection considerations, you can see here the benefits. We talked about the indications, but the risks. So what are the risks? Procedural complications that we'll talk about pretty briefly, but things that can still occur even though it's non-invasive, there are complications that can still occur. What happens if we're unable to see the target? What happens if we are unable to treat the entire target? And then, this is a new device. What's the financial burden to the patient? So going to talk briefly about a case here. You can see the before and after. You can see it's a right-sided treatment, so we'll talk about that really rapidly. So I have a 47-year-old female. This was our 7th case at that time, and it's a patient with colorectal cancer, unresectable because of the involvement of other organs, including the peritoneum and the ovary. The patient did have was on chemotherapy, had a reduction in disease. Fortunately, at the time, and unfortunately, the patient had a segment 6 lesion that was was the only site of evidence of disease, but also was not under control with the current chemotherapeutic regimen that the patient was on. So the patient was sent to me for consideration for treatment. At the time, because of the fact that the patient had extrahepatic disease, while not measurable, the risk was there. And so in a way, it was a balancing act between something that was debulkable and something that was curative. The tumor size was measured at 1.6 centimeters in maximal sense. And then we performed a 2 by 2 centimeter treatment with a 2 millimeter margin. And again, this was in tumor segment 6. And I've described some of the other elements to what we were going to do. This is, again, you saw the pre-imaging location. What you're seeing here on the left side is our preoperative preparation. In a way, what we're doing is, if you think about how radiation therapy is done when they do their simulation, this is our simulation. So there is a tool called Frame that is a histosonics training tool. I would encourage people who are listening that are going to become histotripsy users to utilize this to identify patients and understand who could be a patient for treatment and who should not be treated. But the idea here is you are taking the DICOM or radiological images and putting this into this device, and you can simulate the treatment. Now, the only thing that you cannot simulate is the deformation of the abdominal wall and the internal organs when you place a 20 to 30-pound weight on the abdominal wall when a patient that's paralyzed under general anesthesia. So while this is a great training tool, it does have its limitations. We performed two treatments. You can see here, and with minimal respirations. These are the kind of the treatment characteristics that were put out. But essentially, we did two treatments to overlap the entire lesion. What I would say to you is one of the things you'll learn when you do this procedure is the body positioning. So in the operating room, we'll put the patient lateral, and the way we approached was for the treatment head to come from a lateral approach, and the treatment was to do it in between the ribs. This is key because during the Hope for Liver trial and the Teresa trial, that we know all of the patients that were treated on that trial were not performed in this mode. So this is one of the first patients that was treated in a transthoracic or intercostal method to be able to treat the lesions in the right lobe of the liver. And part of the reason why this was not approached was because of the fear of the lung being a way to obscure our approach to the liver. But fortunately, we discovered that utilizing ventilatory techniques, there is this nice, what I call the triangle of Elasis. He's my partner. But basically a zone of treatment to be able to apply the histotripsy device to an area to the right side of the liver, as opposed to having to do it underneath the rib cage. As you can see here, post-treatment results, a 3.1 by 3 centimeter irregular shape. This was the immediate CT demonstrating acute technical success. The patient was placed back on systemic therapy within the week. And then, as you can see here, following this, following MRI and a PET scan demonstrated basically no evidence of disease, even several months out. So a brief term about our histotripsy program. This is my partner, Dr. Lasses, who is also a user and is proficient in using the histotripsy device. Sam is our nurse practitioner, is kind of our point of care. So for patients that are interested in learning more about our program, she's going to be your point person who will take care of you before as well as after we perform the procedure. I do want to thank our clinic staff and our room staff who are fantastic in helping our patients navigate this entire system. So this is a presentation of mine that we presented this last February at the Advanced Cancer Therapies meeting in Phoenix. This is basically an aim to demonstrate some of the acute technical success and safety and initial results in utilizing histotripsy. Essentially, between December 2023 and September 2024, we reviewed all of our patients to look for acute technical success. The length of follow-up was 3 months. We excluded patients with less than 30 days follow-up, and our primary outcome was the ability to treat, as well as a secondary outcome to look at adverse events. In a way, what we're doing here is repeating the Hope for Liver trial with a larger number of patients, but in the real world as opposed to on a research study. So you can see here we treated 55 patients, a multitude of treatment intents. Many of them at the beginning were abscopal, but then eventually became debulking. As you can look at here in the second table here, pancreatic cancer represented almost 10% of our patients. The most common were colorectal and then cholangiocarcinoma. Just like the Hope for Liver, we were able to achieve acute technical success in a little over 90% of the patients. We did have at the beginning a device complication or device failure, so we were not able to perform the procedure. And again, these 4 people were the inability to target the lesion. Again, this is this idea of a selection consideration. There is a learning curve to be able to choose how to get acute technical success, but it's fairly rapid. Our approach was underneath the rib cage in over 50% of our patients. This is a representation of this idea that by our 50th patient, we were able to actually do a transthoracic or intercostal technique. these 13 patients, sorry, these 19 patients kind of represent the first transthoracic patients done in the United States. We were able to target lesions in all 8, but I would say to you that the best way to describe this is that the procedure can target all 8 segments, but all 8 segments cannot be targeted in a particular patient. So the patient habitus and the distance and where the lesions are located will dictate our procedural success. This is more a representation of patient selection and patient body habitus and patient tumor location as a way to be able to treat patients. We did have complications, including a solitary death. I do believe this fits in line with the kind of complications that were seen in the Hope for Liver trial. Understand, though, that the one patient death is a patient death secondary to a liver failure. So these are patients that we're performing procedures on that likely have a performance status that are a little bit worse off. But it really reflects the safety profile of this procedure because of the fact that we can perform these procedures on patients that are not surgical candidates, or patients that are a bit sicker, that have more advanced diseases. So the fact that the complication rate was this low is a true testament to the safety profile of this of histotripsy. As a result, we did convert to, at the beginning, we did this procedure as an inpatient, but at this point, we do this as an outpatient procedure. Nearly 60% of our patients are done as an outpatient, meaning that they did their procedure and they go home the same day. After histotripsy, the majority of patients were able to reinitiate chemotherapy. A small percentage of them went on to do conversion therapy. And a small percentage were able to receive a second histotripsy treatment. The truth of the matter is that I have done as a number of five histotripsy treatments in a single patient. So performing repeat histotripsy is possible. So in conclusion, histotripsy is safe, technically feasible. We were able to gain independence after 15 procedures, and our efficiency in terms of being able to treat patients with multiple tumors came after 30. We were able to treat a broad range of tumor types, as it was shown in that first slide, and in all segments of the liver. We were able to transition to an outpatient procedure after the 5th procedure. And currently, we have performed over 400 treatments in a distribution of 150 patients, or at least over 150 patients. So we have a lot of experience with this procedure. So that ends my presentation. I will provide my contact information for questions in the future, and I appreciate everyone's attention to my presentation.